Hello, my name is Troy Roach. I am a patient turned citizen scientist researching nicotine patches for long COVID and ME/CFS. And I'm here today with Richelle Sepulveda from Utah. Is that right?
Idaho.
Idaho. Okay.
Close.
Close. Well, welcome, Richelle. You're going to tell us a bit about your experience with nicotine. So, first of all, everybody wants to know, was your experience good or bad?
Experience has been with nicotine has actually been pretty good.
Mhm.
It's been pretty helpful for me. Not 100% of the time. It's
Mm,
not that I'm cured, but it's definitely a very useful tool for me to
mm,
be able to use to help kind of stabilize, especially PEM. So the post-exertional malaise, that helps quite a bit. Not all the time though, but sometimes. So it's like everything with our illness, it kind of ends up, some things work really well, and then sometimes that same thing doesn't work as well next time. And so you just kind of keep testing out different things to see what works best.
And so how long have you been sick?
So I've been, as far as like actually health wise, for about 15 years, I have had some like general the idea of like, is it just getting older, am I just out of shape, and just kind of some gradual decline over the years. And it was very mild, so it was really hard to pinpoint exactly what it was. So just different things here and there, testing different things, my doctor's trying different things, all that. And it wasn't exactly life limiting too much. I mean, it was to a little bit, but not extreme. As a
Mm,
lot of people who are in the mild stages of ME/CFS before it's actually, really made itself clear, it's kind of hard to really pinpoint exactly. The symptoms are very vague. But then in March 2020, March 2nd, 2020, I got COVID. And that greatly accelerated the process. And by that summer, I was actually in definitely much more symptomatic. Definitely, I was trying to decide if I hear a lot of people get wheelchairs, and I was like, well, how would I be able to use that? Because the problem is I don't have any energy to propel myself. So how could a wheelchair actually help me? And I was just like, how do people navigate the world? So I was trying to look into that about like, how can I get a wheelchair and actually use it? What would be the point for me? And because I could go about 20 steps before having to stop and gasp for breath and just rest every 20 steps. So I made crossing roads really tricky. So, but at that point, I really wasn't sure exactly what it was because, again, this was also in the early stages of long COVID. But I ended up kind of more tying into long COVID communities towards the end of 2020 and started to see some, improvements here and there, trying different things. But so that was kind of where my health was at that point. So I did, again, hit pretty significant impact at that. Life started shrinking dramatically at that point, as if that makes, as a lot of us see. And then it was May 2023, so last year, that I first tried nicotine. So,
mm,
so that was, I'm assuming that's your next question.
yeah. I guess you started in May. So what dose did you start at?
Well, I started at the 7 milligrams. In retrospect, I probably should have started at half a dose. But I was having some pretty significant PEM, and I had been, just seeing other people's stories about how nicotine had helped them. And I was like, oh, what the heck? Maybe this will help, maybe not. I don't know. I mean, I can't work like this anyway right now today because I had to take some that week off of work because the PEM was hitting so hard. I thought, what the heck? I might as well try it, see what happens. And so I went ahead and did the whole patch because I was like, I metabolize for things very quickly when it comes to medication, so I usually have to do higher doses of everything anyway. But that was not, like I said, in retrospect, I should have done the half a patch because once it kicked in, I had some people refer to it as like Herxine, but I think for me, it wasn't like a Herx thing so much. I think it was just the huge amount of nicotine in my system all at once. And I had orthostatic intolerance then, which I don't typically get, dizziness, nausea, and the nausea progressed to the point in which I ended up vomiting. And so then after I vomited, rinsed out my mouth, stood up, and walked back to the living room in order to lay back down on the couch. And I was like, I feel amazing, absolutely amazing. I mean, almost to a euphoric level.
Mhm.
And I was like, oh, I feel great. This is it. And I feel hungry. I'm going to go make some dinner. I'm going to go do stuff. And my
Mhm.
husband was watching me and he was like, shouldn't you be sitting down? I'm like, I can't. I can't right now. I have energy. Normally it takes like 4 days to get through PEM. And instead it was just suddenly gone. And
Mhm.
I was actually I was a higher level than what I typically was even without PEM. So
Mhm.
it was like I was just full of energy and, like I said, almost euphoric. Not quite euphoric, but like I don't know how much of it was the nicotine itself or just the removal of the fatiguing element at the same time. And so it was, yeah, I felt really good. And I was, and so I kept staying on the nicotine. And after that, I still stayed with the 7 milligram. I kept that on for, just did it daily then for at least that first month. I did it daily every day. I know everybody's supposed, you're supposed to take time off, but I was also
Mhm.
working full time, and so I really couldn't take time off. And plus, I was also very excited to be functional and being able to walk and do things and do all this stuff. So where before I could walk, but I had to take it easy and I had to sit down and I had to rest and I had to do different things, but I was more or less I could function for the more or less typically. I was actually able to get in like areas where I would get too warm and I didn't crash afterwards.
Mhm.
And so that was also like just an amazing effect too, because heat is one of the more difficult things for me. Always has been, even as a child. But then I have some issues that restrict aspects of sweating and things like that. That's been a thing since I was a little kid. That was so it was so heat intolerance has always been an issue for me. But I was not crashing afterwards, and I was doing pretty well. Went really well throughout that entire summer. So I was actually I didn't have any PEM for 3 months doing that.
Wow, that's
So
very.
so I was working full time. I didn't have any PEM, and I usually don't have a downturn in the fall. Summers are usually where I have my downturn. So
Mhm.
my summer was actually really well, and then in September I started declining a bit. And the nicotine would help, but I was just needing to sleep more, starting to get more fatigued again. Not quite the same level of symptomatic, but more, a little bit more. And it kind of just I kind of kept declining. Actually started bumping up my dose of nicotine and ended up developing a tolerance. But also it just wasn't working as well. And it started to get to the point that it didn't knock me out of PEM like it had before. So I started getting PEM again and just having issues along that line. And
Mhm.
I ended up having to leave my job. So I ended up having to have to quit my job just because I could no longer function at that level. I mean, I was working, coming home, eating a sandwich, and going to bed, basically. And then all weekend I would rest as much as I could just to be able to function for the week. And I was like, well, I'm making okay money, but I'm not living anything else. And I don't enjoy my job enough to have it be my entire life. So I ended up leaving my job, and I still declined even after that. And I was becoming more intolerant to the nicotine. I would often
Mhm.
have to, like, halfway through the day, be getting nausea, and just orthostatic intolerance, even with the depending on whichever dose I was trying. I was just not responding to it as well. Then I started getting some aches in my back, and I realized that wait a second, what this is in my family. We don't often notice when we have a urinary tract infection. We're not usually very symptomatic. We just start to have some malaise. And But since I was getting aches in my back, I wondered if I had a UTI that had progressed to a kidney infection.
Mhm.
So I tested for that, and yes, that's what it was.
Mhm.
So after a significant course of antibiotics to clear that up, nicotine started working again. So when I had an
Mhm.
active infection, it didn't work as well. But as soon as the infection was cleared up, I was functioning again. I could tolerate the nicotine again.
I guess we know that nicotine doesn't cure UTIs.
Yeah, it does not cure UTIs. But I've also kind of been noticing too that if I have any type of, like, anything that's like an acute infection, it doesn't help as much. It's not, sometimes I won't even notice if I have the nicotine in my system, or even if I try to bump up a dose or something. So it's just, but if I don't have an acute infection, even a lower dose, so I ended up getting some tolerance that I can go up now to 21 milligrams without, usually if I'm really feeling PEM, that can knock me out of PEM. But
Mhm.
within like a couple of hours, I have to take it off. And so I end up with a couple of different patches on me because I know one of them is going to have to come off. So that way I can, in a couple hours, but it'll knock me out of PEM, but then I can keep the lower dose on and I'll be fine. But at first it doesn't, I don't have any, when it first hits my system, I don't end up having a strong reaction. It takes it a couple hours for the PEM to get knocked out now. But then after that, if I've got to be careful on how much nicotine in my system because then I start to feel the too much nicotine symptoms. But it's usually so when I'm doing well, I have to, if I try to use a nicotine patch when I'm feeling pretty functional, I have to be on a lower dose. But if I'm feeling more PEM or otherwise more symptomatic, I can bump up my nicotine and it actually helps me out. And then kind of adjust and kind of like tweak it all day. So kind of makes me sad because I'll see that patch that I've taken off and I'm like, do I save it for later and try it again for tomorrow? Or do I get rid of it? I spent money on that. So it's kind of on that, but it's just a really useful tool for me to be able to kind of help navigate and see where I'm at functionality.
So you're still using it regularly now?
Yeah, well, pretty regularly. So it's depending on partly on what kind of tasks I'll need to do in a day, or what my health status is during that day. If I feel like if I know that I overexerted the day before, I will most likely just go ahead and start off with a patch in the morning. I will kind of like test out, like see how it feels on the lower dose, and if that helps me clear up, and then if not, then I'll put on a higher dose or another dose of it just to kind of see where I'm at. But if I do start getting like the symptomatics of too much nicotine, I'll be like, well, nope, my body just wants rest, and that's all.
Yeah.
I usually don't sleep with it on though, because it gives me really weird dreams. But I did one time fall asleep with my nicotine patch on in March, and I've been pretty symptomatic that week, and I'd kind of been upping my nicotine dose a little bit, and I just was tired, and I fell asleep with it on because you kind of forget things when you're in those states, right? And I woke up at 3 in the morning, feeling absolutely amazing, definitely euphoric, and it was. I mean, I'm not a spiritual person really much myself, but it was definitely a spiritual feeling like a connectedness to the whole world, and I felt great, and everything just felt just amazing. I did not feel ill in the slightest. So I made some notes to myself and I went back to sleep, had no problem falling back to sleep. And then when I woke up a little bit later in my normal wake up time, it was actually, I still was feeling it. So it's lasted for about 8 hours. Like that. And then for the next couple of days, I would bump up again to not near the same level of like euphoria feeling, but I'd feel pretty good. And then I'd go back down a little bit and pretty good. So it really matched very similar to the remission events that Tess Fowler has described.
Yeah, like the level 2
Yeah,
remission
level.
events where it kind of feels euphoric,
Yeah,
which I had last for like a day and a half
yeah.
on my
So
fourth day of nicotine, I think. And it
yeah,
happened. No.
so yeah, it was definitely an interesting experience on that one. And feeling like this, feeling really good and really healthy, lasted for, a couple of weeks. So it was just, of course, then when you're feeling good, you feel like I'm going to catch up on life when you need to rest. And so I kept
Mhm.
trying to catch up on things, and I started overdoing it, and then was getting tired again, and then we had some significant things happen. We had a tragedy in our family, and then I got COVID again because being with a family member in the hospital for the whole month, I constantly exposed. I mean, I think I was the only person masking in the entire hospital, so wasn't thrilled about getting another COVID infection. I mean, I try to avoid it as much as possible.
Yeah.
But so it was, and it mimicked very similar to my first COVID infection. So as far as the progression of it, it wasn't milder. It was about the same, had some of the same responses and everything. I was using nicotine throughout it, but I wasn't going too high a dose. So I was just so I could keep and to see if that would make a difference on it. And it didn't really change anything compared to the first one, except for I suppose maybe I didn't have the deep cough quite as long, but it was still. I had the different airway constriction I have, which is tied to some other health issues that I have. The nicotine does help with sometimes, but not always. So it's kind of like Yeah, it's interesting trying to find and navigate what is our original disorder or illness that we had that allowed
Mm,
us to be vulnerable to something like long COVID. COVID itself does do quite a bit, but it's one of those, it's like we all have our own interesting health experiences and biochemistry and genetics, which then make it more likely, at least, well,
mm,
assuming the more infections you get, the more likely you're going to trip that switch, which is
yeah,
what we've kind of been seeing. So again, I would like to not trip that switch as many times as possible. That's my goal. Keep that down. As an anecdotal thing, my husband does not have long COVID, but he does find so I was kind of like, why don't you try a nicotine patch when he was just kind of like fatigued from work stuff and everything, and it
mm,
actually helps him. So he used to do a very low dose. He really
mm,
can't go above the 3.5 milligrams, but that's common for him with a lot of medications and things. But it actually helps him as well, which does match with a lot of other history with nicotine. When we're talking about like depression, it's been studied in treatment for like major depression and that as well,
mm,
and other cognitive things nicotine has been helping with. If people watched the BBC Sherlock, that's something that Sherlock was using in order to help his cognitive processing is slapping on nicotine patches. If you go
mm.
back and look at that, those of us that do nicotine patches, and you're like, he went with the maximum dose. I can't believe somebody would do that to start off with. so, so it's not like magic on that, but nicotine has some really interesting uses that ends up being kind of stigmatized due to its association with lung cancer and smoking. So it's kind of hard
Yeah,
to separate that out. And that's kind of one of the major issues I have with trying to convince people to try it is they're worried about being addicted to it. And it's I mean I'm not saying that worry is unfounded because nicotine is an addictive substance. I mean that's why we call them the nicotonic receptors because nicotine fits better in there than acetylcholine does. They're like I would hate to be have to keep taking it for the rest of my life and I'm like I'm on thyroid medication. I will have to be on for the rest of my life. Other people, there's other things, other supplements I'll probably have to take, at least consider taking for the rest of my life. And
mm,
why is nicotine different? Why does that? And it has to do with that stigma people have with it. So it's not. I mean, like again, I understand why people might feel nervous about trying it because of the
mm,
addiction issue, but it's not the same as smoking because it's not quite tied to the behavioral issue
mm,
and also the consistent dosing over the 20, the time, the timed release or the consistent stable dosing is a very big difference compared to the spike that you would get from, say, vaping or smoking. That affects you very differently. It's a spike and then it's empty, and then spike and then it's empty. And that has more of an addiction tendency. But because honestly, I'll completely forget to put on a patch. I'll be like, I was planning on doing it, and I'll completely forget. And then later on the day, I was like, why was I dragging so much today? And I was like, oh, yeah, that's right. I was going to do that. And I completely forgot. Well, that's a little late in the day. And I'd hate to waste a patch, and because I'm
mm.
not going to sleep with it on. So it's kind of it's,
Yeah, it's funny because everybody's reaction is very different. Because
mm-hmm,
if I try to wear the patch regularly, just in case I get COVID, and the future to help protect from future long COVID issues and brain issues. But the reaction of everybody is different when they don't take it. Like
mm-hmm,
if I miss a day, usually that day I feel fantastic. And then at the end of the day, we're like, oh, I didn't put on my patch. But then like on the second or third day, then I'll kind of feel like a little bit off if I'm not using it for a few days. I don't know. Everybody's different. Some people feel horrible on the patch, and then afterwards they stop the patch, and then they notice that their baseline has increased. So
yeah,
it's
yeah,
really weird.
it's all over the place, and that's where I really wish we had more researchers taking it seriously to be able to
Hmm.
study exactly what's happening with that. Because honestly, I think some of the different reactions people have on nicotine would be a good way to start sorting for subtypes
Yeah, yeah.
about what
Well,
system is actually being impacted with the long COVID, and it's also helped people with ME/CFS that didn't necessarily have long COVID. So it's also, I mean, not everybody, but again, I think that could actually help us kind of at least kind of explore what the different subtypes actually are,
hmm,
which is also why I think treatment is kind of like erratic and difficult in a lot of cases because we're trying to treat everybody that's with the same, let's say, the same treatment and seeing it, if it only works on a very small portion of this group, well, what if we have a whole bunch of different people in there? It's kind
Mhm.
of like if you were trying to do, like, say, cancer treatment, and you can't just say cancer, you have to give me like what type of cancer, like even like say like lung cancer, there's multiple different types and there's different genetics that'll affect different treatment types that'll be more successful. And
Mhm.
so just saying, well, radiation for everybody, that would be like, no, no, that would not be helpful. You'd have to
Yeah.
have it targeted and specific, and you have to know which one you're looking at. And I
Mhm.
think that's also true with ME/CFS and long COVID, is that you have to be able to know what is the triggering mechanism, where is the dysfunction for this person, and being able to look for it. And I think nicotine is actually a really useful way to kind of start, well, these different groups of people have this type of reaction. So starting to
Mhm.
cluster who's in which group, maybe help us kind of look at these different subtypes to be able to come up with better treatments for the different groups. Because especially when you have a lower baseline already, somebody who's moderate to severe, you don't risk things. You
Mhm.
don't have anything spare. And but at the same time, they're also desperate, so they'll often still try something because that is being severe is such a unpleasant state. It's unpleasant and just so destructive to your life. And no, that's one reason when it comes to testing the nicotine patches. While on one hand, I would really hope it may help some of those people. But on the other hand, there are some people who don't do as well on nicotine, and that's always
Mhm.
a risk. And I wish we knew more about why and who it
Yeah.
helps, because those people desperately need more help and support than what they're currently getting, especially from most of the medical establishment, because they're in such a severe state. And so if we folks who are more mild to first half of moderate, mild, moderate, if we can develop the subtypes by testing on ourselves, um,
Yeah.
then maybe we can actually kind of be able to be, you could say, the guinea pigs. So that way, the people who are more severe can have a treatment that they'll have more confidence will be effective, that could
Mhm.
actually help increase their baseline. So even if it doesn't get them to like full mild moderate, just becoming from being from very severe just to severe would be a massive improvement.
Yeah, I totally agree with subtype idea because I see clearly in the Facebook group that there's different subtypes based on how they respond to the nicotine and the different doses that they need and even people that don't respond to it. I think it's even also valuable information for them in the future that they'll know that, oh, I'm in the subtype that responds really poorly to nicotine, and then that will help them know what treatment will be the best treatment for them going forward. I don't know anything for sure, but almost every time when somebody has a bad reaction to nicotine and just it doesn't work for them, I tell them to work on their gut health. Hopefully that helps them.
Yeah. I mean, gut health is key for almost all of us, but it also ends up being a chicken egg thing. How much of it was the gut health led to some of this, and how much of it is part of the illness affects our gut health? Just different interesting things out there, like Dr. Rebecca Ryan, a gastroenterologist and hepatologist. I think she's a hepatologist. Yeah. She was she did a talk for Renegade Research, and it was really
Mm.
illuminating on some of the things that she uses to treat people who have dysautonomia and ME/CFS, and what she does to help kind of help stabilize them, and also how much, and also the amazing thing too is how much she actually listened. And so that was also almost all of the doctors that do really well with people with ME/CFS and long COVID. One of their axioms is almost always to listen to your patients, take an
Mm.
extremely good and thorough and detailed history, and definitely see if they're actually feeling better, despite what you think the diagnosis is. What is actually helping them? How do they feel on these different ones? Because that's their subjective experience is more important than
Mhm.
specific criteria. It's like, how do they actually feel on it? And it's just amazing when you have doctors that are that curious and empathetic with their patients to be able to help.
Yeah,
So,
yeah. And before you were talking about some other theories, hypotheses around why nicotine helps people, and you were talking about the calcium channels and glutamate, things like
For myself, I know I do have a calcium channel issue. So especially there's several. I mean, that's one of the reasons why I don't sweat much and things too. It has to do with the calcium channels and the M3 muscarinic receptor, which is one of the acetylcholine receptors. So there's another place that it's active is also in the lungs. And that's also one of the symptomatic things I have when I'm flaring is I'll get tight in the upper airways.
Mhm.
So it also affects my vocal cords. My vocal cords will start to spasm, so it'll affect my ability to exhale. And also my lungs just get tight. So I can still take a full breath. It feels like there's just not enough air in the room, not enough oxygen in the air that I'm inhaling.
Mhm.
So that's a common one for me. But when I'm using a nicotine patch, that can help it release. So once nicotine kicks in, I can actually then feel my airway open up and release.
Mhm.
So that's a great feeling to be able to breathe because even like your standard inhalers for like asthma and things, they don't do anything besides raise my heart rate. So I just get jittery and have my heart rate spike. That didn't help. I still feel like I can't breathe.
Mhm.
And I get short of breath in those states, start gasping and all. But what for my theory on that about how the nicotine is helping is I'm trying to get the M3 receptor to activate, and so it needs acetylcholine. The nicotine is now affecting the nicotonic receptors. It's another set of receptors that uses acetylcholine. The muscarinic receptors, they work a little bit different than the nicotonic.
Mhm.
So nicotine doesn't affect them, but it does free up acetylcholine to activate
Mhm.
them. And so I think that's part of what's happening for me on that. And it is tied also to the calcium channel issue because acetyl or the muscarinic receptors that especially like M3 and that they do then allow the calcium channels open. So that's yeah, it gets we start getting into all the little minute chemistry into that. That's part of the direction of where it's going on it. There's also the one that so that's what affects me. That's why I think it's helping me a lot. But for
Mhm.
a lot of other people, especially the ones that may not feel as well on the day of they're taking nicotine or they're taking it for a course of several days and then they're not so then they have days in which they're not taking it and they feel significantly better. That matches really well with Kat Boniface, her theory of the glutamate hypothesis about
Mhm.
the glutamate cycle is dysregulated and the nicotine helps reset that because again acetylcholine and glutamate do have and those calcium channels actually have a lot of overlap.
Mhm.
And so she's kind of seen how that the basically if your glutamate system is this is where you're at this dysregulation, the nicotine can make them rebalance. So
Mhm.
that way, and then when you stop using the nicotine, you're more balanced and then you're more stable for a little while because that's stabilized. But if you were the other direction and you try the nicotine, you're actually going to get worse. And that would be
Mhm.
part of the reason why some people do very poorly on the nicotine, even when they remove the patch. And that would require another intervention besides maybe nicotine, but maybe later in the course of like after treatment or after other stabilization, it actually may be very successful,
Mhm.
which we know that from everybody with long COVID and everybody with ME/CFS and fibromyalgia and all of our dysautonomia, all the associated conditions, is once you stabilize one thing, now a previous treatment that didn't help or was made you worse in the past may be actually really effective for you.
Yeah.
So it's kind of that's why there's never a one and done with our health. We're kind of like constantly moving all over the place. And so trying to find that spot where we're stable is kind of where we go. That's why we have our little toolbox of things that help in different times. So she's got
Yeah.
some really interesting theories on how the nicotine's working and other things to do to support the glutamate system, which would then actually be able to maybe make nicotine work for those people that it's not working for right now. So it's so she's got some fascinating theories on that,
Mhm.
which would be, I think, extremely relevant for why nicotine's working and not. So it's glutamate and then GABA. So that's another. Those are commonly known as just neurotransmitters that people think about at various times, but it has a difference because they do recycle into each other. They're part of each other. One becomes the other and then goes back as part of the cycle. But if it's
Mhm.
over too much in one area and too little in another area, that can affect that dysfunction. So there's some other parts to it too that are different ones and maybe more helpful or others. So there's also the incretins like GLP-1 and GIP. So those ones that are tied to insulin release. But then also there's also other tie-ins with how nicotine affects those, which is always, you've always may have heard in the past that people, when they give up smoking, they're going to gain weight, and people blame that on the fact that you're doing something now with your mouth. So you're eating more things instead of smoking. But more research is showing that it may actually be tied into a change in GLP-1. And nicotine may be actually able to support higher levels of that, which, like the whole classification of weight loss drugs out there right now, like semaglutide, Ozempic, all of these ones that are originally for diabetes, but now they're using them a lot for weight loss and not. They're finding a lot of actual neurological effects on them too.
It actually like blunts the effect of like addictive behaviors of sugar and even nicotine and drinking and things as well.
So it does blunt some of that, but also there's also you use a lot of GLP-1 actually in the brain, and the two main areas that produce it is the caudate nucleus, so the solitary tract, which is in the medulla, so part of the brain stem. That's one of the big areas, and then also the olfactory bulb. Those are the two areas that produce the most of it for your brain, because what's in the rest of your body is not necessarily crossing the blood-brain barrier. And now we're finding it does a lot of other things besides just those things. Like it's critical for stabilizing your CSF levels. So actually, they're finding as a side effect of these medications, people who had idiopathic intracranial hypertension, their CSF levels are stabilizing, so they no longer have that higher pressure. So they're no longer having the effects of the high pressure in their brain. So it's there's a lot of like downstream effects. They're finding more and more positive neurological benefits, but not for everybody. Again, like the nicotine, it's also making some people worse. But other people have neutral experience and other people do really well. Again, if we knew more subtypes, we could make better determinations. But it looks like nicotine does have an effect on the production of GLP-1, which has a lot of other effects in the body as well. So it's kind of, there's so many little effects. It's never just a single one thing, a single cause, especially with such a complex patient population as we are, that it's just fascinating to start to see that this is actually opening up like a huge area of research and possibilities. A lot of it because we patients are doing exactly this, which is just, this thing's helped me a lot. Why? And the doctor can see that this did help you a lot. I don't understand why. And so the right curious doctor is going to be like, well, I want to look into this and see what made a difference. Patient research, just experimenting on ourselves and then networking with other people who have tried different things is actually such a critical component of how we actually can move research forward for our condition and actually help others and be able to help ourselves as well to at least get back some of the life that we've lost, expand our life a little bit versus being, as we're shrinking our life down into a single room, it'd be nice to be able to expand it out a little bit more, to be able to get back to at least some aspects of life that we lived before. May not be able to be 100%, but that's one reason why anytime I'm in like with nicotine, I was like, people say, so did it cure you? And I was like, I'm currently in remission. I'm not cured because I know it's going to come back and get me eventually. But I'm enjoying it this summer. Like last summer, I was just like, I'm enjoying the summer. This is an amazing summer for me because I can get too hot and not crash. I can just go get cooled off and I'm all right. Versus, which I hadn't been able to do before. I could sit in the sun every now and then, which is something that I couldn't do before without being stuck in bed for a couple of days. When I say sit in the sun, I'm talking about like 15 minutes and going, look, the sun. I mean, that was such a difference compared to what I had been before. So it was, so I was like, yeah, I know I'm just in remission. I'm not counting this as a cure. I'm sure it'll come back. And it did, especially as I got that UTI. But it's definitely something I'm going to keep using as a tool and find out more mechanisms on why it's working, because I think that gives us an idea too about the underlying dysfunction, the specific causative dysfunction that's leading to these issues, what's causing the illness in general. I think it makes a big difference to understand it that way. So I'm really excited about where research is going to go with this, because it's such an easy treatment to try as a patient, and there's such a network of people that are very supportive, like you mentioned, the Facebook group. Also on other social media platforms, people ask about it. And then also, we're all also people in our lives that you otherwise talk to or interact with. You're also a very good chance that you're like, and they're like, yeah, I'm just getting so much older already. And I'm like, you're 25. That's not typical aging. You shouldn't be acting like you're 40 when you're 25. That's not how your body should change that quickly. And it's like, have you thought about long COVID? I kind of feel like I'm a proselytizing long COVID sometimes because it's yeah, to see like, and that's one of the things I've actually done that. I carry nicotine patches around with me sometimes if I'm anywhere out and about. And then if I'm talking to somebody that is someone I know, like a family member or something that's talking about how they're feeling that they're aging, I was like, have you tried one of these? See if it makes a difference. So very rarely they take me up on it, but every now and then they do. So they'll see if I carry masks too, just in case. So that way I can be like, why don't you try this?
Well, that's bit by bit, we're all making a change. Everyone's getting the word out more and more people are trying it. And so it's fantastic. It's interesting seeing the stories of all these people in the Olympics getting sick with COVID and then worrying about them pushing themselves to the point where they're getting long COVID. Then I notice now that there's a lot of stories that of athletes that couldn't go to the Olympics because they had long COVID, so they just couldn't go. But those stories don't make the headlines as much. And even one of the athletes, she couldn't go to the final meet to be able to go to the Olympics. And then after that, she found the nicotine patch and tried it, and she said after a week she was cured. If she had known about the nicotine patch before, then maybe she would have been able to go to the Olympics. But
Yeah.
we have to get the word out.
Yeah, I'm concerned about those athletes too, just as it also a lot of us when we were first sick, especially if we had a tendency towards hyperfocus or otherwise ignoring our bodies sometimes, which a lot of elite athletes do. They're used to being able to push through that part of where their body's telling them to stop because they're, that's part of how you get to those elite levels. But when you have COVID or long COVID, that's one of the worst things you can do. I'm wondering how many of the people in this Olympics are going to end up with some aspect of long COVID. And so I guess we're going to have to see in about 6 months where they're at. That's usually that marker. But yeah, getting the word out. If there is a big surge of them that have long COVID, maybe they would be great people to talk about nicotine if it does help them. And maybe that would actually help. Getting it in some of those circles could help. Hard to say. We'll have to see how it goes. Because again, it's a lot of us are desperate for treatment, and it's something that again is pretty harmless to try for the most part. Not everybody, especially if you're severe. It's not something that's should be taken just as a well, maybe this will do something. It has to be very well thought out. But it's something that a lot of people can try because the barriers to trying it are quite low. So it does. You don't need a prescription in most places. If you are listening to the other patient groups, it makes it, dosing and how to, use the patch so that way you're not like cutting the whole back off and you're not cutting the patch in half, things like that. It makes such a, having other patients saying that what worked for them and how it worked can help quite a bit. But that gives people a chance to try it. And again, the more people that know about it, the more people who will know about it, afterwards. And so, and again, I really think it'll help with subtyping, but it does make me wonder how many other conditions something like nicotine could help with, or if there's something else that's similar to it. Like there's been research before that it's a really effective treatment for depression. But which is one reason why if somebody's depressed and is a smoker, they actually quitting smoking can actually make them worse. But for at least temporarily while they're in the remission or in their withdrawal stage. But also that's also something to think of too. If somebody has long COVID or ME/CFS, and they're a smoker, sometimes trying to quit smoking, smoking itself is not good for you, but quitting smoking can make your symptoms actually be more prominent. But again, nicotine patches may be a great support to be able to help you through that too. I mean, it's better than the actual smoke itself.
Have you read my HSP hypothesis on highly sensitive people.
I read part of it, but yeah, go ahead and let me know a little bit more about it.
Because I found that so many people were joining the nicotine test study that were with ADHD, they had ADHD and autism. And I was like, why are half the people I'm talking to in this neurodiverse group when it should just be everybody from who has long COVID? So then when I was reading a book on highly sensitive people and basically saying that it's just more broader way of saying that you're neurodiverse because your neurons are more sensitive to stimuli. And then I realized that I was a highly sensitive person. So then I started asking people and doing surveys. In the surveys, 90% of the people with long COVID and ME say that they identify as highly sensitive people, which is 90% is a lot more than what it should be, because in society it should be 20%.
Yeah, that's what I say. I was thinking it was like 15-20%. Yeah.
Yeah, so only 20% of the population would be highly sensitive people, but here in these communities it's 90%. And there's also there's a lot of documented use of nicotine in these neurodiverse communities. The more neurodiverse you are on the spectrum, I guess, the more likely you would be a smoker as well. So maybe they're just kind of medicating themselves with the nicotine. Whereas if maybe from an earlier age they were treated with nicotine or some other type of substance, then they wouldn't take up smoking in the first place. That would change a lot of things, but also would also explain some of the benefits that people have from the nicotine and why some people say that they're not going to stop. They're like, I'm going to keep using nicotine forever because this is better than any of the ADHD meds I take.
Yeah.
So
I've heard that one several times. I mean, actually having ADHD or an autism diagnosis does actually make you more vulnerable to long COVID anyway. That is something that we've seen from very early on, that was actually one of the that was the group that was much more likely to get it anyway. But it's also about exactly what's the cause of it. There's again, part of it is the genetic tendency to be more reactive to the environment, which actually fits into Kat's hypothesis a bit with glutamate. But there's also some calcium channel stuff in there too. So there's also some genes associated with calcium channels that actually significantly affect neurocognition. And they can affect, some other things too. There's also other emotional states that are also part of sickness behavior. When I say sickness behavior, a lot of people think of that as kind of like a mental thing about sickness behavior, as like this is something that you should have self-control over. But actually, the term sickness behavior came out of veterinary medicine. Like that's how you know your cat is sick, is because they sleep all the time and refuse to eat. So that's considered sickness behavior. So that we can observe that there's something going on in your animal, but you don't, your pet or whatever, but you don't know what it is. But aspects of ME/CFS and long COVID mimic what is known as sickness behavior, because it's like your body's trying to curl up and hibernate to try to get over whatever it is, but we can't clear it. We get stuck in that part of the health cycle about trying to get through it. But there's certain association areas in the brain that gets activated during that can get stuck on. And one of them is part of the grief system. So the grief system is something you have to constantly suppress. You're constantly holding it back. And if it's fully activated, like all of the grief system is activated, that's actually a panic attack. But it's the feeling of being connected to other people is one of the best ways to actually suppress it. So that's why if you're lonely, you're feeling it, and why it's almost like physically painful, because it does also, it's connected right next to a lot of your pain areas. If that system is activated, which it does when you are inflamed, when you have neural inflammation, otherwise illness in the body, it's trying to get you to connect to other people, but not put too much energy into it at the same time, because you're putting so much energy trying to navigate the system. So then there's other parts of the brain that are all part of that. They're doing different other networks that are actually being dysfunctional too. But that's also another part of it, that it's the nicotine may be suppressing aspects of that system without having a lot of this extra work that we have to do to constantly hold it back. So it might be just a really interesting way that it may be just, you might find somebody who's very reactive and has a tendency towards anxiety and panic attacks. It might be helping them for that reason, rather than necessarily just the illness itself. So it's kind of there's a
Yeah.
few other areas of the brain that are critical in this one, like I mentioned, the caudate nucleus of the solitary tract and the medulla, but that's got some other things connected to it. But yeah, I'd
Yeah.
spend a lot of time talking about neuroscience, but that's probably going to be, anybody listening to this may actually kind of go, oh, well, that's a little too much. And I'll be like, yeah, I got to stop myself sometimes.
What you mentioned the caudal nucleus of the solitary tract in the brainstem,
Hmm.
and I was just discussing research about mice where they found that the sickness behavior response
Hmm.
is localized in specific neurons in that part of the brainstem, and
Hmm.
you can just activate it. You can turn it on and off just by activating a couple of neurons in your brain. So it's a physical, with a physical change to your brainstem, you can activate these
Yeah.
issues. And it's in your head, but it's not in your head.
Well, it's a thing that I say a lot is like, the mind is the brain and the brain is part of the body. So things that affect
Mhm.
the body can affect the mind.
Mhm.
And that's an exact thing of it. So the idea it's that this separation, this dualism of the mind versus brain, it's, well, all of your thoughts are actually neurotransmission and coordinated patterns of firing in your brain. And so interrupting that or changing how those work can actually cause other downstream things. But
Yeah.
yeah, that's part of in that caudate nucleus. That one is since where it is in the medulla, it's also really prone to aspects of compression, especially if you have a CSF leak in your spine, which
Mhm.
causes the cerebellum to kind of come down, the tonsils of the cerebellum to come down and squash the medulla right there.
Mhm.
Or if you do have Chiari malformation, full Chiari malformation, or you have some other cervical instability, it can cause that area to be more likely to be compressed,
Mhm.
which then could be part of a mechanical trigger for the illness itself and starting off and triggering this, cascade of effects that end up making everything worse.
It's also
It's
like the junction box for the vagus nerve as well.
mhm.
That's like the junction box connecting the vagus nerve from the body to the rest of the brain. And it actually has like neurons that go all the way around to
Mhm. And it's also right
different.
next to the trigeminal nucleus too, where your trigeminal nerves are actually processing and sending their information. So,
Mhm.
which is also a critical one, especially when we talk about fibromyalgia.
Mhm.
In these, that there's a lot of impact in that too. So yeah, it's a thing seen more on the brainstem itself, especially the medulla. It ends up being really the pons in the medulla are really important in a lot of the illness behavior, not just behavior, but illness symptom and thoughts, which is also why I often try to tell people that a feeling of guilt, shame, especially intrusive thoughts of it. I mean, if you don't have OCD, but you start catching these intrusive thoughts, it's kind of OCD like of these intrusive thoughts, feelings of shame, and especially like in that histamine dump that if you have, having MCAS and you wake up in the middle of the night and you have this intrusive thought you can't shake and it makes you feel bad. It's usually about something that you've done in the past or you should have done or you didn't do, or all of these things. It can actually cause you to have these thoughts. That actually could be just a symptom of the illness. Like if you catch yourself going like, I'm not actually anxious about things in the world, but I'm like anxious. I've got anxiety. What is this?
Mhm.
Yeah, stabilizing MCAS can help a lot, but it also part of it is because that is a lot of the things that get degranulated from the mast cells can affect that. But it's also affecting that system there, and it can cause a lot of that dysfunction aspect that leads to a lot of unpleasant things. So yeah, having that mood aspect, a lot of people will describe it as part of the first stages of PEM. Anyway, you'll know that that's actually part of being sick. Is this
Mhm.
feeling of loss, helplessness, shame, guilt, and often some really dark thoughts can pop in there. And That's not necessarily because you have the illness and that makes life suck. It's not necessarily due to that. It's because of the illness, because it's actually a symptom of it.
Yeah.
It is being triggered by aspects of neurotransmission. So that's also things I like to mention to people about like this is something that you're your emotional regulation and your ability to control your thoughts also can be disrupted. So you may not have the control to be able to do things when people say, "Oh, just stop thinking about it." And be like, "Well, sure, I would love to. I would love to just turn that off." But
Yeah.
that's also something too. I'd be curious to see how many people describe a difference in those kind of intrusive thoughts when they're on nicotine. Again, not saying somebody who has OCD itself. OCD is its own disorder. It's got some similar symptoms as what this is, and but we haven't necessarily seen OCD makes you more. It's a little, maybe a little bit overrepresented, but not the same as what you'd see with ADHD. It's its own thing. It's just the guilt, shame thoughts that come up often with ME/CFS and long COVID are similar. That's why I always say OCD, not quite the same thing, but it is. It's just it is as difficult, not quite as difficult to control, but it's still difficult to control, especially if it's not something you have had since you were a child, which a lot of OCD starts in your toddler years.
Well, you definitely have a lot of knowledge on this topic because you work as you studied. What was your
Sure.
profession?
So my degrees are in psychology,
Hmm.
and I teach psychology at the local college here.
Hmm.
Um, so that's kind of part of it. Plus, but actually, a lot of these things I end up having to. They weren't necessarily my standard psych background, but because of my psych background, I was able to look more in depth in it and to see these subfields and the different ways that the different areas of the brain work in the different parts of it, and like talking about like dyspraxia and motor movements and
Hmm.
the yips. So athletes may know about what I mean by the yips, and then
Yeah.
ADHD and dyspraxia, what those actually are. That's actually yeah, it's a just as a just as a side note on an interesting study I saw on the yips, which is when you have like an athlete, usually golfers, but it's also a lot of athletes can have it, where a task that they used to be able to do well, now they just keep screwing it up and they can't do it right anymore. I
Hmm.
actually saw a study that treated it with L-Dopa, and it was actually really successful.
Hmm.
And it was just more of like, not saying you should be taking L-Dopa for like sports enhancements. I'm not saying that at all. But it's interesting to know that it is part of that pathway. And there may be
Yeah.
other ways we can affect it rather than that. So, not saying nicotine necessarily would help, but it's an easy intervention to try. It's just, well, it just kind of means that there's so many of these things overlap. And
Hmm.
there's so many different areas in which we can kind of start to see what is the brain doing and why in
Hmm.
different populations to be able to help us also see what's going on in our illness.
Yeah.
To be able to understand that what might be the dysfunction. Is it dopamine? Is it glutamate? Is it just the calcium channels? Is it compression of the brainstem? Is it TNF alpha or IL-6 that are more of a problem? You know, there's a lot of different things that could be more of a significant issue with one person or another.
Hmm.
And maybe nicotine treatment and the subtyping that comes from it will actually let us be able to see what the source issue is so that way we can have more effective testing. Because right now, if you're trying to get testing, the testing itself is exhausting and can cause more symptoms. If you're getting actually effective testing, a lot of times they'll stick you in ineffective, testing that isn't actually helpful.
Hmm.
Like how many people have done a tilt table test and lost baseline. It's actually very common. If we can find out more about subtyping, especially when you start seeing about different ways people's brains actually work, typical people, people with who are neurodivergent, people with TBI. There's so many different ways you can start to see these to see about how we might be able to find ways to actually help more people instead of
Yeah.
just, you know, well, figure it out on your own, which is where we're all of us seem to be kind of are right now, which is why the patient community is such a great network to be able to tap into so you can find other people that react to things like you do, and then you find out what helped them and see if that might help you.
Yeah. So are there other things that's helped you that you think you suggest people to look into other than nicotine?
Well, for besides just the nicotine, one of the things that I will often say gave me my brain back was
Mm.
taking a copper supplement. But that's not something that I necessarily suggest for everybody. It's kind of more of like you have ferritin, iron, B12, copper, zinc, these ones.
Mm.
If you are low on one of those, they greatly affect a lot of aspects of your ATP production and a lot of different things. You know, they're very critical elements to have in your body. I was testing, looking at those, looking at my numbers on B12, which a blood serum test is not necessarily going to give you a good accurate one on that, which actually saw a recent study that found a woman who she had her CSF B12 levels tested compared to her blood serum levels, and her CSF was actually almost no B12 showed up in it at all versus her blood serum. And so they actually found that was a significant cause of her dysfunction. So I was like, that was fascinating. But blood serum may not give you all the answers, because is it actually getting in the brain is going to be a big one. But so I thought I would just try. I was like, well, I hadn't tried copper, so I'll try that one. And I thought I would try it for like a month and see how it goes. Within 5 days, I had basically my brain back. So I could actually hold a thought, and I could actually do some focus. I mean, I wasn't anywhere near like a remission or anything, but there's the difference when you just can't maintain a thought pattern for like 5 minutes and you're scattered and everything fractures constantly when you're trying to think something. You can't remember why you picked up this object in your hand. It's just that you just picked up and you're looking at it, and why did I do that? That's that's one of the big dysfunctions of brain fog aspect, or one of the parts of it. And taking copper helped me quite a bit with that. But again, that's one of those you gotta be careful with it, because also if you can't process copper out properly, you can start to build up in a lot of places it shouldn't, and that can be really bad. So especially if you are of Irish descent, you definitely want to get that checked. There's specific genes to look for, see copper genes, that kind of thing. So that was one that helped me out quite a bit. But again, I've seen other people have reactions like that to ferritin or B12 injections and things like that too. So it's those are some critical ones. Also NAD has helped me quite a bit. I mean, I was taking niacinamide to start off with, and then NAD, and that's actually, that helps quite a bit on a lot of my function. I'm trying to think if there's anything else that was really as significantly helpful as those ones, as far as like energy and focus, and as to be putting them up there on it. So it's just, D-ribose has helped sometimes, but not others. It just depends. For me, the ketogenic diet helps quite often. It has helped me out. But there's also some aspects of like, you may actually, certain like infections like COVID can actually impact your liver's ability to really generate ketones properly. So you may not actually be able to generate the ketones. You might have to do exogenous ones, like take MCT oil or something. But it's critical for support of your T cell. So that's actually a really interesting study out there too, about how ketones actually are a big part of what your CD4 positive T cells actually, how they are actually what they feed on, kind of. And if you're have that cycle broken, then overnight or other parts, you're not actually using glucose well, and then which again, we know that quite a bit from a lot of us, don't process glucose well. It's that's one of our issues. But it makes your CD4 positive T cells just start to starve because they're only about half fed, which then causes a lot of downstream dysfunction. So that can be part of the help with that. So it's helped me out significantly. But I also have a lot of food restrictions because of MCAS, which is also something I would say, regardless if you want to try nicotine patch or not, definitely try stabilizing mast cell activation, because a lot of us have that. It is part of your innate immune system response. So it is one of those things that does it's extremely commonly dysfunctional in almost all of us, one way or the other. And if you're like, oh, I don't think I have an issue with that, it's like, well, you might and may not realize it. That's just something you may not have realized, that you've been dealing with this for so long, and then you get treatment for it, and that's how my intestinal system is supposed to operate. Which actually, once I started nicotine, I actually ended up stabilizing aspects of that, kind of the bowel system properly. It actually helped with that somewhat too. So it did help stabilize aspects, my MCAS. So that was nice. Yeah. Not saying it's guaranteed to treat that, but it's just one of those. Once I've stabilized my MCAS, that's probably given me a lot more support and stabilizing a lot. I'm having less swings in health, if that makes sense. A lot of that ended up being about finding out which foods I'm reactive to, which, sad to say, garlic is one of my most reactive ones. I get anaphylaxis if I have garlic. Wow. Which, it's delicious and it's in everything. So there's a few other things like that too that I'm like pretty reactive to, especially like a lot of different like artificial sweeteners, coconut, different other stuff, things like that. Basically, if it's delicious, there's a good chance I can't have. I still have a few things out there. I still have cheese. I'm glad I still have cheese. A lot of people finding out the foods that make you more reactive is a critical one. But also with MCAS, finding the right types, histamine blockers and mast cell stabilizers that are going to help you is a
Mhm.
huge part of like aspects of recovery and stabilizing. Just because if nothing else, they can cause damage in a lot of different ways. Actually, they can degrade your the stuff with like histamine and other things released by your mast cells can degrade connective tissues. So you may
Mhm.
not have been really hypermobile before, but you could start to be more hypermobile. And you one of the joint areas that you really don't want that to happen to is your neck, because if you weren't unstable there, after this you might be unstable, and that could end up causing more of like the caudate nucleus or the trigeminal nucleus or other issues from being compressed and nothing else, horrible headaches, which you don't want. But it can also then affect aspects of orthostatic intolerance and things too. So again, it's like that's always so. I would say that it's with that I can't just say it's like a single med that helps. It's finding
Mhm.
out what works for you because again, we're all reactive to different things and different excipients that are in different medications and things can make such a huge difference on how well a particular medication may work for you. So yeah, it's those would be the things I would say that helped me the most. One of the things that stabilized I take to help stabilize my mast cells is aspirin.
Mhm.
It's a good mast cell stabilizer, but there's a lot of people who can't take it for a lot of reasons. Sometimes they can have reactions to it, or the blood thinning issues with it, or whatever. But so I've been lucky that that one's one I'm able to take. But there's a lot of other ones out there that are really helpful. So kind of like you have to find a doctor willing to work with you on some of those, given
Mhm.
also which country you live in too, because some of them are over the counter in some countries and prescription only in others, or the reverse. So trying to find the ones that work for you makes such a huge difference. But yeah, it's kind of a again, we're all a little bit different. We all got our own little things too, so it makes it trying to find out what works, and also keeping track of what makes you worse is a critical one because it also lets you know some of the mechanism of what makes your health kind of go down. Because if you find out this thing makes you worse, whatever it might be it nicotine or be a particular antihistamine, the
Mhm.
mechanism of action could actually be part of what is kind of like what is the area that is the dysfunction for you that may be able to be targeted by something else. So even if something doesn't help you, that's still giving you information, still giving you data. So it's still
Yeah.
important to track.
Okay. Well, thanks a lot for taking time away from your weekend to talk with me and to share your story with everybody. So anything else to add or?
I'm trying to think if there's anything else. Honestly, I would say for anything, for some of this information, if you can do it, the other things I'd like to direct people to is the Remission Biome Renegade Research YouTube channel
Mhm.
because of the different webinars they've done with different experts. There's a lot of different, like they did a series with Dr. Afrin, a leader in MCAS research, and then, like I said, Dr. Rebecca Ryan, a gastroenterologist that's got a specialty in, also Ruhoy and Kaufman from the Center for Complex Diseases. So it's just there's a lot of really good information on there,
Mhm.
but they have a tendency to be a little bit long, so you may have to take them in chunks. But they're really really informative. So I do kind of like to direct people to those because it's a way to be able to access those experts if you're especially if you're geographically restricted.
Yeah.
Yeah, that's just a thing to consider on it because it gives you at least some of the information of what they look for, what they're treating with their particular specialty in this. And it also, if nothing else, it lets you know there are doctors out there who care, especially
Mhm.
if you haven't been able to find ones in your own local network that seem to care or understand or take you seriously. That you're not alone, and a lot of us have gone through that. Almost all of the doctors in that series talk about PTSD their patients have from how they've been treated in the past,
Mhm.
and that's something that almost all of us have dealt with at some point. I don't think I've ever run across somebody that had with our illness that had every doctor they interacted with be a positive experience.
No.
So it's so if nothing else, it's really refreshing to know there are experts in this that believe us and are really wanting to help us. And
Mhm.
that's even if we don't get to talk to them personally, just knowing they exist helps a lot. it's really hard emotionally for a lot of us to deal with that bracing impact of that doctor's appointment. And are they even going to believe me? And if they believe me, can they actually understand it? And if they can understand it, is there actually anything they can do to help? It's really easy to avoid going to doctors because you don't feel like they'll help.
Yeah.
One of them, Dr. Afrin, that's one thing he did say. It's also the other thing is it's not everything's MCAS because people have other things too. But if they don't go to the doctor, those don't get come, and you'll end up with so you have to listen to them to be able to actually see what else is going on, or else they won't come in. And which is important for us too. So yeah, that's why I just like to direct people to that. So it's Remission Bio on YouTube.
Okay, I'll put links to that in the show notes of the video as well. Well, thank you very much, Richelle, for sharing your experience with us. Well, that's it for today.
All right. Well, thank you.
Bye
All right,
bye.
thank you for having me on. This is fun.